need it actually. Oh, I might need it for the online research. We're all good online? It's all right, we're not going to start with two. Wait for Ursula. There's a horde of people about to come in for. Yeah, that'd be nice. Okay. Good morning, everyone. Can you hear me okay? Great. And I should say hello to those online as well, with the camera up to my right. So it's a pleasure to welcome you all here this morning to officially open the Alfred Health Research Week. As always, I'd like to begin by acknowledging traditional owners of the land on which we meet and pay our respects to elders past and present, and also to recognise ongoing connection to land and waterways, and to welcome in particular any First Nations people who are joining us either in the room or online this morning. For those of you who don't know me, I'm Adam Horsburgh, and I have the privilege of being both the CEO of Alfred Health, but also the chair of the Alfred Research Alliance. And obviously we're here today to celebrate incredible research that is conducted across all of the Alfred Research Alliance members. And there are 8 members, as many of you may know, located here at the Alfred campus. That includes 3 universities, being Monash University, La Trobe and Deakin, 2 world-leading medical research institutes in terms of the Burnett and the Baker Heart and Diabetes Institute, 2 clinical research trial specialists, being the Nucleus Network and 360 Biolabs, and of course 1 health service, Alfred Health, that's at the centre of the collaboration. So to kick off the Alfred Research Week, we are celebrating the work of some of our outstanding researchers who have recently received NHMRC investigator grants. These grants are highly sought after and prestigious, as they provide recipients with a level of certainty, security, and the flexibility to pursue an ambitious research programme over a period of 5 years. Receiving one of these grants gives recognition that a specific area of research has the potential to improve understanding, lead to health improvements, improve health outcomes, and indeed provide wider benefits to society. It's impressive that on this precinct, 21 researchers from Alliance partners have received a combined total of $42.9 million in National Health and Medical Research Council investigator grants. And today, we're going to hear from 6 of the successful recipients. So I would now like to introduce you to today's host, who's going to bring this showcase together. Back for a second year is Dr. Shane Huntington, who many of you may know from his popular RRR radio show, Einstein a Go-Go, but who is now also the CEO of the Australian Society for Medical Research. Shane did an excellent job for us last year with a high energy, fast-paced and informative session, and we are delighted that he's taken the time to come back this year. Shane, we recognise that you have an incredibly busy schedule, so we are really appreciative that you've taken the time out of that schedule to be with us again this year. So please all join me in welcoming Dr. Shane Huntington.
Well, thank you very much, and thank you for the introduction. My organisation has run 5 gala dinners and 1 national press club event in the last 7 days. So if anyone says to me chicken or fish, I will lose it. I will lose it. But it is a pleasure to be back, and especially for today when we're talking to 6 people who've managed to get through what is one of the most ridiculously challenging rites of passage that a researcher can ever face, and that is our current grant scheme, which, you know, when you see success rates around 10%, I call that culture changing, not just annoying. So it is at the point where people are often afraid to talk about it when they are successful, because so many people are not. So today is a great example of what we have to keep doing, which is to talk about our successes when we have them and celebrate them as we always have done and not hide away from that. So we're going to hear some great talks. Getting grants is hard, but being told that you only have 6 minutes to present for a lot of researchers is a little harder. So we're constraining people quite heavily today. And one of the presenters has already apologized to me because they think they're going to take 7. It could happen. Each presentation will have about 10 minutes. And if we've got time, I'm going to ask them a few questions after they present. And if they're really short and succinct, we'll have time for a couple of questions from the audience as well. We do have people online, so we may get a few questions from them during the course of the proceedings. In the notes it says I should tell people to turn off their phones or put them in flight mode. I don't think I even put my phone in flight mode when I'm in flight. People are the same these days, because every now and then you fly a bit low, you can pick up signal. You need to check your email. It happens. It happens. I came back on Wednesday night last week from Canberra, 100km/h winds. I figured it was fair that I'd be able to say goodbye to loved ones. Yeah, it was pretty touch and go. I told a friend of mine who's an air traffic controller, we landed. He goes, "Really?" That worried me. Anyway, I digress. First up, we're going to hear from Professor Jason Ong. Now, Jason is the director of the Melbourne Sexual Health Centre, and his grant, he's been awarded his research, in particular around HIV, for going the last mile to end HIV transmission in Australia, ensuring no one's left behind. Sounds so much better than 1.609 kilometres, doesn't it? The last mile. I don't like miles. What's with the miles, Jason? What's going on? Kilometres, man. Kilometres. Oh, we have to correct it. Please come up and address the audience, and congratulations.
Thanks so much, Shane. Yes, I need to upgrade to the metric system. So thank you very much for this opportunity to share. Okay. So when you go to parties, people often ask you, what do you do? Without jumping, within a few seconds, my wife, who often is next to me, will jump in very quickly and introduces me as a sex doctor who models. And it will either kill the conversation, or it's absolute silence, or people will be curious as to what I do. Okay. Something weird happening to my slides. Sorry, so there's some missing words there for some reason. No, okay, all right. Anyway, there was, going back, let me just go back a moment. Yes, so I'm a sex doctor in the sense that I'm a sexual health physician. So I work at Melbourne Sexual Health Centre, and I have done some modelling work, which is, sorry, the one before, which is missing from this page here, which is unfortunate. This is the Victorian HIV plan. So I have done some modelling on the side, but scientifically, I built infectious disease models, and I also built decision models to predict people's behaviours and epidemics. So I work at the interface of these four kind of methodologies. So I'm a HIV specialist, but I am also trained as a health economist, and I specialize specifically in a method called health preference research, and also work as an epidemiologist as well. As far as I know, I'm the only one in Australia that has this combination of skills. So that's been very helpful to get grants. For my investigator grant, I've built a suite of, or integrated a suite of methodologies. So at the bottom is what I call crowdsourcing, which is learning from the crowd, the wisdom of the crowd, to get them to tell us what should we be doing about the problem. And I'll share with you what the problem is. Discrete choice experiments will help us prioritize what are important aspects of whatever intervention comes up. And then behavioral economics or nudging is when we can kind of optimize the design to account for human kind of cognitive biases. And then the economic evaluation is to show you the value for money. So changing policymakers' minds about what to fund and not to fund. And then ultimately at the end is to be able to change policies and make a real difference in people's lives. So STIs, that's quite a lot of STIs, but I've only got 6-7 minutes. So I'm going to focus in on HIV, which is the focus of my investigator grant. When I talk to Uber drivers or taxi drivers and tell them what I do, they often ask me, is HIV still a problem? And unfortunately, it's still a common kind of misunderstanding out there that HIV is no longer a problem for us in Australia. In some ways, the answer is mixed. Is it a problem? For certain groups, it is not a problem. So Australian-born gay bisexual men numbers are dropping over time. And this, Australia does serve as a beacon of hope for the rest of the world that we can beat HIV. However, the focus of my research is the leaving no one behind. And we know that certain subgroups of people are not getting the same benefit from our HIV response. UNAIDS has this 95, 95, 95 goals, which means that of those who are living, 95% should be diagnosed, 95% go into treatment, and 95% gets their virus suppressed. And missing text. Not sure what's going on here. Sorry, I'm clicking through missing text, and I can't remember what's there. Anyway, working through this. So there are two main things that I'm focused on my investigator grant. So one is HIV self-testing, which is the ability to test within 15 minutes of getting your actual result. So it's a game changer in the sense that rather than going to see a doctor, you can just buy a kit over the counter. So one of my aims of my research is to be able to scale this up. And we've already got money to do it in vending machines. So as of this year or as of next year, there'll be 60 of these vending machines all over Australia. We've also already got a program where people can be mailed out HIV self-testing kits. So we're trying to learn how do we use this better for those who are being left behind. Sorry, missing text. The next one is social network testing approach. So this is the way to harness, I guess, people's, so this little cartoon here, so this person will get 4 kits, they will test themselves, but they will distribute out the kits to their other social contacts. So that's an idea that's been going around the world, and we help WHO get some global guidance around that, and we want to test that in Australia. The next big idea is HIV PrEP. How do we keep people protected against HIV? So there are, again, certain groups that are at high risk for HIV. So we do build this, I'm sorry, this full of missing text, apologies for that. There is something called Designathon, or the crowdsourcing part, where we learn from the crowd, from communities, what do they want. And this is an example of a designathon. So we get groups of communities to come together. It's a bit like a hackathon. So people within 72 hours will generate some results, and they compete against each other in teams. And they will generate whatever solution related to self-testing, related to PrEP itself. This example I have here is called PrEP-STAT, which is something that we will be testing. And this idea completely came from community. This is not us as experts thinking about this. So they came up with these 3 concepts: love yourself, feeling loved, sharing the love. Love Yourself is a free 1-month pack of PrEP, which is 99% effective for protecting you against HIV at the point of contact. So as a clinician sees someone who's at risk for HIV, they'll be able to give them the pack and also a prescription as well, and some body wipes if they want to use that. Feeling Loved are messages directly from community. So they're able to hear directly from people that look like themselves, maybe not that one there, but messages from people part of their social cultural groups. And they'll be able to understand, why should I be using PrEP? And the other one is Sharing Love. So we will also build into our intervention the ability to share or pay it forward to the next person. So yes, you've received this free pack of PrEP. How can you pay it forward to the next person to get the free PrEP? And this is not coercive, it is completely voluntary. But we found this, we've done this in China as well, and we've found quite good effects. So all of these will end up in a clinical trial and again, get the value for money. So I'm gonna stop there with my 7 minutes. Thank you very much.
Thank you, Jason. I'm sorry we removed all the text that we didn't think was relevant, but you did very well to compensate for that. One of the first questions I have for you is, in each of these cases, you have an initiating person, like you start with someone
Yes.
who you then utilize in the community.
Yes.
How do you go about identifying those sort of super spreaders or anti-super spreaders, as it may be? Yeah.
Yeah. No, it's a great question. And it's, these communities are often hidden or unreached for a reason, and that's why they're kind of being left behind. And it's taken more than 10 years for my research journey to be able to connect with these community groups and then getting the trust from them. And then once you get the trust, actually, it becomes easier in the sense that they will be the one that refers. They have skin in the game, I guess. Then they are the ones that will step up and say, let's do this because it's for the benefit of our communities. So that's where we, at least for the social network trial, that's how we harness that network.
Are there other areas where this has been used other than HIV? I mean, I think I could probably hand out to a lot of my friends the bowel cancer tests.
Yeah.
We're all of similar ages, and I know how many throw it away because I think it involves an ice cream container. But are there other examples in other, diseases and so forth where this sort of methodology has been used?
I'm sure that there could be. I haven't done an actual scoping or systematic review. We did do it for HIV specifically. So this is something that we published 2 years ago. And we found 47 other studies globally that was already using this idea of the HIV self-testing kit and disseminating that.
And you mentioned China, but what about in some of the more, challenged environments where it's a lot more difficult?
Yes.
Are you going to take the same approach down the track? Is that the goal?
Yeah, so with our international work, Asia and particularly our Asia Pacific region has some of the fastest HIV epidemics in the world. And we know Fiji is in the news, for example, and Papua New Guinea just north of us. These ideas haven't really been tested out in those environments, but I see a lot of value, and we will be reaching out to partners to discuss that.
Very good. We have time for one question if there is one from the audience or online. Yep, just over the side here.
Is it a great thing that
Yes, yep.
rather than cheating, taking money away? So with the scheme, with this anchor people, will they also distribute PrEP to the cohorts that, or they would have to go to a doctor, because that kind of limits the usability of such a people scheme?
Yeah, that's an excellent idea, and perhaps one for my next investigator grant after that. But yes, currently we're constrained because of regulations around PrEP being distributed by peers, but it's an idea that's been floated around even amongst community. Can we actually get a few pills and give it to people of our networks? We know it's already happening. It's in the community, people distribute pills in that way, but we can't officially as clinicians do that because that's against our regulations. But it's something that we are exploring. Thank you.
Amazing. Thank you, Jason, and congratulations. Okay, next up is Dr. Emma Foster. She's already told me it could take 7 minutes. So there's a big warning for Emma because I will stand up ominously if she gets to 8. Emma's working on, in particular in epilepsy, on transforming epilepsy management through evidence-driven approaches. Over to you.
Thanks, Shane, and thanks for the organisers for inviting me here today. So epilepsy is the commonest brain disorder across all ages. Over 250,000 Australians live with epilepsy. It's associated with a 2 to 3 times increased risk of death. And importantly, it's treatable. And because of that, it's a disease of significance for the World Health Organization. Now, the number one goal of treatment for epilepsy is to bring seizure freedom. And some health economic modelling work we did in Australia showed that if we could improve seizure freedom by just 10%, we could save $1.1 billion in healthcare costs, we could prevent over 1,600 deaths, and we could add another $7.8 billion to the economy by keeping people well and seizure-free and at work. And so this is the focus of my NHMRC program. It's to identify strategies to maximize seizure freedom through early diagnosis and improving medication adherence. So let's imagine someone has a seizure. In the perfect world, they'll be attending medical care and receiving a correct diagnosis. And we know from international studies, if you can see a specialist early, you will be diagnosed quicker, you'll start treatment sooner, and you'll use healthcare less. In reality, in Australia, 50% of people will have at least 5 seizures before they're diagnosed. And with those undiagnosed seizures, they're at risk of seizure-related accidents, injuries like bad head trauma, or even death. So this is work I've done led by Dr. Yung Tong Lee, my honours student, where we looked at the effectiveness of first seizure clinics. First seizure clinics are an Australian innovation. They're specialist rapid access clinics where people have a first seizure and then they see a specialist in one of these centres as soon as within a few weeks' time. They're very resource intensive though, so they're only available in a few Australian centres. This was a pilot study, so we only looked at 2 first seizure clinics. So you can see over here, the mouse isn't showing, but on the left there, these are people who've come to first seizure clinics. They're significantly less likely to need to go to emergency departments or be returned to hospital for admission compared to people who fail to attend first seizure clinics. And we can see on the left, people who come within 2 weeks of being referred versus after 2 weeks are significantly less likely to return to emergency departments, need hospital admissions, have seizure-related attendances, and they have reduced mortality compared to people with a delayed attendance to first seizure clinic. So this pilot study shows that if you come, and if you come early, it can make a big difference to future healthcare utilisation. So leaning into this, my NHMRC program will look at whether first seizure clinics are cost effective to in terms of reducing future healthcare utilisation for people with first seizures. So let's have a little look or a deeper dive into what data linkage is. So this is person A, and we're going to follow their healthcare journey. So they have a stroke and their data is put into different administrative data sets. So their emergency department attendance, their hospital admission, and medications they prescribe all get put into these separate data sets. They then develop a comorbidity like blood pressure. Again, their GP visit, their specialist visit, their medications are all stored in administrative data sets. They have a first seizure, and so this person now becomes of interest to me because I study first seizures. They develop epilepsy, they have a car accident, so all these different data are put into the different data sets. They have a fracture, and then sadly they die, and in this case they go to the coroner's court. So with data linkage, I will pull out data from all these different administrative data sets for person A and have a journey of their healthcare utilisation. And with data linkage, you can do that for tens of thousands of people with the disease of interest, and you can follow them for years, if not decades, depending on how long the administrative data sets have existed for. And so you can have really granular, comprehensive epidemiological journeys for these diseases. So for this project, I'll be taking 40,000 first seizure patients and comparing them to age-sex matched controls and seeing what happens if people come to first seizure clinic or don't come. And via data linkage, we'll establish healthcare utilisation, medication prescriptions, investigation use, the development of new medical or psychiatric comorbidities, and any accidents, injuries, or deaths over the follow-up period. And so this project will help us establish the impact of first seizures, and the cost effectiveness of first seizure clinics, which is fundamental to be able to increase their presence around Australia. Now, once we've improved early diagnosis, the next important point is to support medication adherence, which I'll do through qualitative studies. We know that 2 in 3 people living with epilepsy can become seizure-free on medication alone, but the rocky reality is that 1 in 2 people are non-adherent to medications, and we know from a Melbourne study that if you have declining adherence, it's associated with an 8 times increased risk of sudden unexpected death in epilepsy, which is a leading cause of death in young people with epilepsy. So our foundational work was led by my master's student, Ali Conquest. We've conducted interviews with healthcare providers all around Australia, and we established certain factors that help support medication adherence for people living with epilepsy. It includes establishing routines, so taking medication when you brush your teeth morning and night, because our medications are usually twice daily, setting smartphone alarms, screening for depression, which is far more prevalent in people living with epilepsy and can interfere with people's ability to take medication, getting family support, providing personalized written medication plans, and delivering culturally appropriate and safe healthcare. So based on this pilot study, the research program will go into much more depth with lived experience focus groups and healthcare provider interviews to understand epilepsy treatment knowledge gaps, design interventions, assess their feasibility and acceptability in centres, including the Alfred, which is Australia's largest comprehensive epilepsy centre, and then rolling these interventions out through our epilepsy advocacy organisations. So coming together, we've got early diagnosis, medication adherence, and it will help optimise seizure freedom. Those are my thank yous.
Yeah. You're right on 7 minutes. I like it. One quick question for you here, Emmett. When you speak about seizures, obviously they come in a million shapes and sizes, and the common view of a seizure is not what often presents with regards to epilepsy, and people can have different sorts of seizures for many years. I mean, how will you account for the less sort of typical type of seizure?
That's such a great question. So as Shane said, there are many different types of seizures, and the way a seizure looks depend on where it comes from in the brain. I guess from a very layperson perspective, we think of a seizure as falling on the ground and shaking with all 4 limbs. In reality, the majority of seizures that happen, particularly in adulthood, are far more subtle. People can have this intense feeling of deja vu. They might have a rising sensation. They might hear something. And it's often very difficult for a bystander to know what's happening. And often the person has got impaired awareness during it, so often has trouble recalling it. That probably is one of the reasons that we have 5 or more seizures before an epilepsy diagnosis is made. So what our team has done is I've led a study where we've gone through about 1,000 people with first seizures who attended 5 of our major epilepsy centres around Melbourne. So through a retrospective study, we had 2 junior epilepsy doctors and then the senior head of clinic verify what each diagnosis was. So we included the whole scope of what different first seizures looked like. We then matched that to what the administrative records showed, and we're building and validating an algorithm based on the administrative data sets to pull out not just the convulsive seizures, which are easily marked, but also the non-convulsive seizures, which are more common.
Yeah, amazing. Thank you so much, Emma. Thank you, Emma, for us. I think epilepsy is one of those areas that reminds me of earthquake predictions. Like if you give someone 10 seconds warning, the things that they can do, the way it changes their life is phenomenal. We all don't think about what 10 seconds means, but it means so much in terms of driving, using equipment, everything. So it's a huge, big deal. Well done. I'm good. You've got to get it done now, with the grant. Next up is Professor Jonathan Shaw. Jonathan is the Deputy Director of Clinical Science at the Baker Heart and Diabetes Institute, and no surprise, he's working on diabetes, in particular, on the causes and the population burden. Jonathan, over to you.
Well, thank you very much for inviting me to speak today. And I didn't make any promises about how long I'd speak for, so. Okay, so hopefully in 6 or 7 minutes. Firstly, a bit of background about diabetes. It is, of course, one of the most common chronic diseases. There are over 1 million Australians with diabetes and hundreds of millions of people with diabetes worldwide. It's the most common cause of end-stage kidney disease. It's responsible for more than half of all non-traumatic lower limb amputations, most common cause of visual loss in working age adults, and a major contributor to cardiovascular diseases. And on top of those sort of traditional risk factor complications, there's now emerging evidence of a whole variety of other complications. And in a review published a couple of years ago, led by Dee Tomic, one of our PhD students at the time, we kind of divided what we understood many years ago about the typical classical complications of diabetes, divided into the microvascular kidney disease, eye disease, some aspects of neurological disease, and the macrovascular, all there in blue on the left. And this large body of emerging complications, part of it is due to us recognizing things that we'd never spotted before. Part of it is because as a result of some of the better treatments and outcomes that we see from the traditional complications, it's allowed people to live long enough to start to acquire other conditions, particularly perhaps things like dementia, which has now become a major consequence of diabetes. So thinking about how the world is changing and the landscape for diabetes is changing, it really does lead us to ask a number of questions. Out of all of those complications, if we just follow the textbooks and go with the traditional ones, perhaps we're missing where the main burden of complications is. So what is that distribution? What is the burden? We now have a number of interventions with newer drugs and perhaps some better uses of older drugs that are very effective for some of the complications. But how are those being delivered? And are they getting to the right people? Are they actually making a population impact? It's great to do clinical trials and science to discover new interventions, but we then have to track them to see how well they're actually making an impact. Other issues are, especially as the landscape changes with complications and things are altered by some of the interventions that we use, how best do we predict these different outcomes? And that's important so that we can identify the right individuals to treat intensively with the right treatment. And then sometimes when we find these targets for risk factors, they are also worth exploring as potential pathophysiological targets to develop new treatments and new interventions. So, standing on a body of work that I've done and that my team has done and that others before me have done, we put together this outline for the investigator grant that I was fortunate enough to get awarded. And it really looks at two common but rather distinct areas of epidemiology. The top row there, cohort studies. Recruit individuals, measure them in detail, deep phenotyping, and then try and predict outcomes in those individuals. That has great strengths in that you get to do really detailed and uniform testing across all of the individuals, and you track their outcomes with precision. The problem is, of course, that you only get the volunteers who turn up, and they are not necessarily representative of the broader population, or certainly don't capture all the aspects of the broader population. And so, as we were hearing in the previous talk, we also have a significant component of this on data linkage, essentially bringing together data on whole populations, not volunteer populations, but whole populations, and tracking them to see what's actually happening in the real population. Do we have more heart attacks? Do we have more strokes? Do we have more kidney failure? How does dementia compare as an outcome to all of those things? So just briefly, what are we doing specifically for those two different parts of the program? Cohort studies, we have a study that began a few years ago called the PREDICT study, which has now almost recruited its target of 3,100 participants, a population-based cohort of people with type 2 diabetes who are being deeply phenotyped, scanning, questionnaires, measurements, and a large biobank of all sorts of things that we might measure in the future. And then we follow people up over time for their outcomes. And this will give us real insights into the risk factors, the pathways, potentially mechanisms, certainly the ways in which we can identify individuals who are at the highest risk of a whole range of different complications of diabetes. And the second part is data linkage. Data linkage comes in a number of different ways. For diabetes, at least in this country, we have a very nice list of almost everybody with diabetes across the country, but there's not much on that list other than names and who they are and that they have diabetes. But by linking that to a variety of other data sets, examples here being the prescriptions database, hospital admissions, mortality, registries such as cancer. This becomes a very powerful way of tracking what is happening at a national level so that we really know which direction we're moving in. Are the interventions that we're paying for delivering the benefits that we would hope for in the population that matters? So locally, we do that with those sorts of linkages. We've also added to that a consortium that we run that's established with my collaborator, Professor Diana Magliano, who's here, where we've put together a consortium of more than 20 countries around the world who have similar kinds of registry data. We came up with a novel way of being able to analyze everybody else's data without having to deal with the privacy issues of accessing that material. And that gives us really exciting and informative insights into what's happening not only here, but in a range of different countries around the world. Collectively, we hope that these studies will really drive forward what we understand about the complications that people with diabetes face and what we can do to identify the people who are most at risk and implement treatments in them to reduce that risk. Thanks very much.
Well done, Jonathan. I suppose one of the questions I have here is, obviously, as we go through various age groups, the complexities of diabetes go up quite markedly, especially many comorbidities. How effective will this work be at sort of identifying those in sort of perhaps the earlier age groups for whom there are unexpected, additional complications as you've been identifying? Is that part of the outcome?
Yes, so that is actually part of it. So clearly the issues of diabetes vary by age group. In some ways it does get more complex as people get older, but actually there are different things that affect people at different ages. One of the things that we're particularly interested in is younger adult onset diabetes, because in recent years that's exploded for type 2 diabetes. It used to be thought of as being middle-aged and elderly people. We now see it commonly in people in their 30s, into their 20s, and even occasionally in teenagers. And we have a separate study that actually Diana is running where we're looking specifically at those individuals and also younger adult onset type 1 diabetes, because from the other end, type 1 diabetes has been typically seen as a childhood onset disease. In actual fact, more people develop diabetes among the adult population than amongst children. And we also have a number of issues in differentiating type of diabetes among younger adults. So that is a specific focus that we have a study called Prediction that is focusing on.
And do you have to do anything specific with the non-Australian databases to make sure they're kind of normalized to the point where you can use the data effectively in a comparative sense with ours?
So the biggest challenge actually is getting some access to them, and we came up with kind of federated models of analysis so that actual data never has to leave, the data itself never has to leave the analytic center. Really, the beauty of this is that because they are full or almost full national data sets, there's not a lot that you have to do. You've got to adjust for age and for sex. But apart from that, there's not a lot that you have to do in order to be able to make comparisons. Most of our work focuses on the global picture of it rather than the individual comparisons, because of course there are many differences between countries, not only in ethnic makeup, but also things like how the healthcare system works and how data are collected.
Amazing. Thank you, Jonathan. Great work. Okay, we're halfway through. Is everyone still here? No one left? No emergencies? Sometimes people in the hospitals fake that there's emergencies. They leave because they're bored. Last year, no one left. I think they were just feeling very, very self-conscious about walking out after I said no one left. So anyway, next up is Associate Professor Nick Scott, who's the Head of Modelling and Biostatistics at the Burnett Institute. He's also an Adjunct Senior Research Fellow at Monash University and an NHMRC Emerging Leader Fellow. He's using modelling to guide the elimination of hepatitis B and C and HIV.
Thank you. Thanks for coming. So I'm going to talk about allocative efficiency, and I'm going to explain it through some example work we've done in the past. I'll just echo the acknowledgement of country that was given earlier. I'm going to talk about some work we did in 2022 in the Eastern Europe and Central Asia region. Firstly, to start with, allocative efficiency refers to providing the highest value health services for available resources. The work we did included 12 countries in the region, and the two main questions we were asking at the time were, firstly, how can current HIV spending be optimally allocated across programs for the greatest impact? And then secondly, what resources would each country need in order to reach the UNAIDS 2030 targets? So these are the 12 countries that we looked at. And the whole purpose of this analysis was that we were developing submissions for these countries to put into the Global Fund so that they could receive funding for their HIV programs. And rather than go through all of the countries, I'll just pick one. So this is an example from Belarus. And what we did with each country was we worked with their teams to collate all the data they had about the epidemic, including things like population sizes, new infections, deaths, care cascade over time. So these panels show, sorry, there's some text that's kind of come up on them, but each dot shows the data that the country might have on things like the prevalence of HIV among sex workers, men who have sex with men, or people who inject drugs. And we work with the country teams to try and figure out which were the most reliable and fit the model to that. Once we were all happy with the way it was looking, we got information on the current programs that they were doing, including their spending and their reach. So this figure shows what the optimization analysis did. The bar on the left shows the current spending on programs. It's about $15 million in Belarus, and you can see how it's divided, most of it going to antiretroviral therapy, but funding for other programs. And what we found is if you could optimize that by having more emphasis on antiretroviral therapy and HIV prevention programs for people who inject drugs, by deprioritizing general population testing, you could get much more impact for the same amount of money. So 23% reduction in infections and 9% reduction in deaths. We also estimated that in Belarus, for this example, they'd need an extra 32% more funding in order to be able to reach the targets. And we quantified for them, sorry, the figures come a little bit unaligned, but we quantified the impact that this investment could have on HIV infections. So you see in the black if they did the status quo, in the green the optimized, or the orange if they invested more. And it was really interesting working with the epidemics for each of the different countries because they had such big differences between them. And this is a snapshot of that. I've got 6 plots here that show the new infections over time for each country. The colours are the different population groups. So orange is people who inject drugs, purple is men who have sex with men, and there's others there too. But you can see that the peaks of the epidemics and the shapes of the epidemics are very different. The groups being affected are very, very different, and so we needed to capture this in all of the models. Here's another few examples, and again, just to note that they're very different when you just look at them, and we had to make sure that the model captured that. And basically, we did that same analysis for each of the countries that I showed you with Belarus. Because of the differences, the recommended spending was different between countries. We found that in general, prioritising ART and key population programs was better than general population programs. And there were major differences between countries. In particular, many countries required probably new interventions to reach these targets. So where to from here? Well, most of you probably know that international spending on HIV and funding's being sort of shredded a bit this year, so there's a need to ask different questions. And really the focus is if you have reduced HIV spending, what should you maintain in order to have the least bad outcomes. And so that's going to be a focus of this work going forward. And we're also going to look at hepatitis B and C, which I didn't talk about just for time. So many thanks to everyone in the team who helped with that.
Thank you, Nick. And Jason, I think we found your missing text. Maybe. In terms of, you've looked at so many different countries here, and the variation is quite astounding. Do those countries have very different models of care, or are there different other dynamics in play? Like they are quite different when you look at that data.
Yeah, very different. They have lots of differences in models of care, but also different approaches to HIV. So some countries, their governments are a bit more conservative, and they kind of don't provide programs for a lot of key populations, and they have more infections and bigger epidemics in those populations. And some of the downward trajectories are where countries have decided to scale up needle and syringe programs and other programs like that. So yeah, I can actually see the impact that they've had.
And I don't think I've seen so much data in one slide before. And it was actually pretty easy to read to see the comparison between all of them. When you do this and when you look at optimized conditions, I mean, are you moving into sort of the AI world there with regards to optimization modeling and so forth? Because it seems like an incredibly complicated set of parameters for even just one country, socially and otherwise, to optimize what then happens as the response.
Yeah, we don't use that in this, but there's a lot of talk about people using more of those AI tools to analyze some of the data that's available and to try and make it more useful as inputs for tools like this.
Yep. And how fast does the change have to be? Like when you see some of these lumps and bumps and so forth, if we're to optimize spending, governments move pretty slowly in some of these areas. Like, what kind of timeframes are we talking about for that to be, to get the optimum results, or actually to at least see that the spending is leading the response as opposed to lagging it?
That answer changed a bit this year. So previously, Global Fund and others funded a lot of the international response for HIV, and so they could just change their mind and just change what got funded. But with all those cuts, there's more reliance on domestic spending, and then it goes through the local political process and probably much slower.
Yeah. Are other jurisdictions taking up some of the load that we're seeing removed by the US?
It's difficult to say yet.
Watch this space.
Yeah.
Yep. Thank you, Nick. Great work. Good luck. Okay, and next up is Associate Professor Emma Ridley. Now, Emma is an NHMRC Emerging Leadership Fellow at Monash University in the School of Public Health and Preventative Medicine. And I think your grant is very timely for your career, isn't it? Because you're just on the end of one grant and jumping into the next. Tell us all about it, Emma.
Thank you very much. Thank you for the invitation to speak today about my fellowship, which starts next year. So our colleague and friend Jacko Washner, who spent about 12 months with us at Monash University many years ago, wrote this beautiful editorial where he surmised that survivorship will be the defining challenge of critical care in the 21st century. He proposed that we're a bit distracted with mortality rates and we actually forget that most of our patients now survive, but with devastating impacts to the quality of their survivorship. And that's where I hypothesized that allied health therapies such as nutrition and rehabilitation, or perhaps the combination of those two things, are really going to impact the quality of survivorship for our patients. There's no doubt that critical illness is devastating for our patients, and this is a seminal work from Zudin Puthakere from the UK, and he used rectus femoris cross-sectional area to characterize the degree of muscle loss following critical illness. And even in patients who have single organ failure, which is a very common presentation for us, they lost nearly 10% of their muscle mass in just 10 days. And the sickest patients who have multi-organ failure lost more than 20% in just 10 days. And you can imagine if you have a long ICU stay, the impact of that. And it leads to devastating impacts on quality of life, functional improvement, return to work, and it lasts out to 5 years. And at the moment, we have no strategies that actually can prevent this.
This is coupled with the fact that there's problems with nutrition in this early acute phase as well. And globally, our patients receive about 1,000 calories per day or up to 50 grams of protein. And it doesn't matter which geographical region you look at, and this hasn't changed in many years. So it then makes sense that many studies have then tried to investigate this. And so this is just in the past 10 years, many studies have tried to overcome this, thinking that perhaps if we could provide more nutrition, we might stem that muscle loss. But to our surprise, many of these studies have shown minimal clinical benefit, and actually some have shown harm. And this has all been in the 10 years that I've been developing my career in critical care nutrition. So you might think maybe I should choose a different topic. And I've thought about that as well, but as an academic clinician researcher, my biggest question is why? Why have we seen this and perhaps not some of the answers that we thought we might see? So perhaps the design is an issue. So part one of my fellowship is the development of novel trial design in critical care nutrition. So nutrition is a complex intervention, and traditional trial designs are slow, and these are two issues that definitely exist. Traditional parallel RCTs have a rigid single hypothesis framework, and that makes them very good for drug trials, but perhaps not for nutrition, which is a complex intervention with differing treatment effects, complex interactions, and heterogeneity of treatment effect, and a parallel RCT just can't overcome many of these things. So if we look at the questions on the right-hand side, these are legitimate things that we might ask. And to study these things with the traditional design, we would require 4 trials. It would take approximately 28 years if we use the average 7 years from funding to publication rule to answer one question in one population only. In 28 years, I'm going to be in my early 70s, and I'd like to retire before that. So I need to rapidly work out how I can answer some questions so I can retire feeling comfortable about my contribution to science. Adaptive platform trials are a novel trial methodology, and they're a very hot topic since COVID. And in adaptive platform trials, patients are allocated to domains to test multiple interventions at once. And the interventions can be tested in different populations or strata, as they're known in an adaptive platform trial. And it's more efficient, cost-effective, and has near immediate translation potential. And it can actually cope with things like heterogeneity of treatment effect or interactions between interventions to a better degree. Now, in my short presentation, that makes that sound very simple. It's not. It's very complicated, and it's very complex for nutrition. But we hypothesize if we can establish feasibility and get the right infrastructure, we can answer a minimum of 8 critical questions within the next 5 to 10 years, with capacity for near immediate translation into clinical practice due to multiple interventions being compared at one time. Part 2 of my fellowship is looking at extending nutrition interventions into the recovery phase of illness. So this is the metabolic phases of illness, and each patient goes through this in their critical illness. And basically, the importance of nutrition seems to vary according to phase. And at the moment, we have most of our trials in this acute early period, so around up to day 5, with very few trials looking beyond that in terms of nutrition interventions. This may explain why we've seen this signal for harm, because perhaps at this period, our patients are not able to metabolically process the nutrition we're providing, and it may be placing more metabolic stress on a system that's already stressed. This has been supported by really beautiful work by my friend and colleague Leanne Chappell, who showed that critically ill patients' use of ingested protein for muscle protein synthesis is markedly blunted despite normal digestion, meaning that just giving more is not going to be the answer to overcoming that muscle loss that we saw and improving functional recovery. Importantly, very few trials have looked at nutrition interventions in this late recovery phase, and we think this is when we may be able to impact recovery in a positive way. This links very nicely with an overarching aim of my research program, which is what is the lived experience of nutrition in the later phase of and following critical illness. And this builds on a larger project called Nutrient 2, which is a very large project in 60 hospitals around Australia and New Zealand, MRFF funded, and it aims to improve nutrition care for patients following critical illness. It consists of 3 streams. So stream 1 is understanding the consumer experience of nutrition. Stream 2 is clinical data collection, so we can have a real world scenario. And stream 3 brings those 2 things together so that we can redesign a model of care based on consumer and clinician preference. The important things about this project is that it has the first dedicated consumer committee for critical care nutrition that's guiding the whole program. It focuses on nutrition across the whole hospitalisation period and not just that acute period that I've just talked about. And it will lead to the design of a new model of care that will have to be tested in future research, but it will allow provision of data for future hypothesis generation too. So the logical next step, which I'll take in my fellowship, is what happens at home. So I really want to understand what's the lived experience for patients with nutrition following critical illness when they get home, and then co-design the first individualised pilot RCT to commence in late hospitalisation and extend after discharge to investigate the impact of nutrition on recovery for critical illness. And with that, I'll just say thank you. Too many people to thank in my journey for a very quick presentation, but thanks to the whole NHMRC, the Alfred ICU, and the Alfred Nutrition and Dietetics Department, and the patients and families who contribute to our work.
Thank you, Emma. Nutrition is obviously a very complex thing, and I think, as we spoke earlier, it is you guys are going to become the rock stars of medicine in the next 20 years. I do feel, alongside physiotherapy and optometry. But one of the things I find curious here is, how do you, in real time, monitor sort of the nutritional needs in that early period? Because what's needed on day one, whether or not it is met, presumably will change fairly rapidly, and the person's ability to take on various changes in nutrition will, be highly variable from person to person. Like, how do you measure that in real time, monitor that, adapt to it?
So at the Alfred, we actually measure. So we have something called indirect calorimetry, and we do measure in real time. I guess where science needs to catch up a little bit is, even if you measure, what do you then give? Because you don't necessarily need to chase that number, and that's probably a gap that we don't quite understand yet. But that's not a practice that's done internationally. So that is a big gap with the literature, and it is where we probably need to improve. And as you say, the issue is, and this is probably where the science will go, is that every person is different and will probably need an individualized strategy. And we're not quite at that point yet.
Yeah. And when you spoke about the previous ones that, didn't really go far, you mentioned that some of them had even caused harm. Can you speak to that? I mean, I can understand sort of absence of improvement, but what sort of harm did come out of those?
Yeah, so the harm really speaks back to the physiology, I guess. So it's things like increased regurgitation, increased vomiting, increased gastric residual volumes, which is a sign of intolerance, I guess. And so if you think back to the physiology, that potentially is the body saying, I don't want this at this time, and perhaps it needs more time to recover. A lower level of nutrition just for baseline, and then when they're able to recover properly, that's potentially when we should step in.
Yeah. Do we have to sort of up the capabilities and standards in some of our major hospitals with regards to provision to meet specific sort of needs of some patients, or have we already got what we need?
No, I think we need to develop expertise so that we can appropriately provide nutrition for different patient groups, and obviously map to the different phases, because it's definitely not a one size fits all, and that's probably how we've approached it to date.
Yeah, amazing. Well, congratulations again on your grant. Thank you. Okay, well, very last now, we're up to Professor Anne Holland, who's a professor in physiotherapy and head of respiratory research at Monash University and Alfred Health. And Anne is going to be talking about the advance of non-drug treatments to improve lung health. Physiotherapy is my favorite area of health, closely followed by optom, then neuro, and I don't want to talk to the cardiologists at all.
Thank you, Shane. That's a great introduction, and thanks to the organisers for asking me to present today. Okay, so my investigator grant will address the burden of chronic lung disease, so diseases like COPD and pulmonary fibrosis. We know that these are diseases that have a huge cost both for patients and for health systems. COPD is our leading cause of potentially avoidable hospital admission in Australia, and altogether lung diseases in Australia cost us over $1 billion a year. Non-drug treatments are really critical to best care of chronic lung diseases, and this includes things like pulmonary rehabilitation, so program of exercise and self-management education, oxygen therapy for patients who are hypoxic either at rest or during exercise, and self-management to keep people well and out of hospital. But access to these treatments is extremely poor, both in Australia and around the world. And why is this? Well, there's a lot of reasons, and here's some of them. So we know that models of care are not typically aligned with patient needs and preferences. That's particularly around asking very debilitated people with lung disease to attend appointments repeatedly in a face-to-face setting. We have inadequate clinical trial design to test some of these quite complex behavioural therapies. They're not a pill. We have a not very good understanding of how to personalise treatments related to endotypes and phenotypes. And even when we do know what to do, sometimes we're not measuring whether we adhere to the guidelines. So in my previous investigator grant, we focused very much on pulmonary rehabilitation, and we focused on transforming that model of care to take it to the patient, both in low-cost home-based models and also remote delivery. And if you're interested in that work, we were fortunate that the NHMRC published a case study on our program, so that's available online. So in this investigator grant, we will extend that further to focus on some of the other non-drug treatments, and we've got 3 streams of work here. So the first is around novel clinical trials, the second one around targeted treatments, and the third one about driving uptake of evidence-based care. So for the first objective, novel clinical trials of non-drug treatments. So we know from our previous pulmonary rehab trials that about 1/3 of people will decline to participate because they already know what kind of treatment they want to have. And that's a problem for RCTs, where if somebody knows that they want to be treated at home, they won't consent to a trial where they might be randomised to get something else. Patient choice is, of course, critical to behavioural treatments. You need to be choosing something that you're prepared to do, and we need trial designs that will take that into consideration. To add to our problems, we know that many patients live away from trial centres. So we've shown in pulmonary fibrosis that 1/3 of people live more than 50 kilometres from a clinical trial centre and thus are unlikely to participate. And we only have 1 clinical trial centre which exists outside a capital city. We also have some ongoing gaps in evidence, and that's particularly true for self-management training in pulmonary fibrosis, where the approaches so far have been unproven. So in this stream, we'll look at 2 clinical trials. The first one is the SMART PR trial, which is a sequential multiple assignment randomised trial, which will allow us to really assess the effect of giving people a choice and the point at which we give them a choice of their rehabilitation model. So this is similarly an adaptive trial design like Emma was talking about. Under the hood of these things, there's quite a lot of statistical modelling before you can take them forward and get them off the ground. And so the investigator grant will allow us to do that modelling. The second trial is Master PF, where we'll take a self-management package we've specifically designed for people with PF with people who have PF, and we're going to test that in a respiratory teletrial. So that will enable us to reach those people who live away from both clinical trial centres and live in rural and regional Australia. The second objective, targeted non-drug treatments for those at high risk. People with COPD have frequent exacerbations and they're not benign events. They portend bad things, including future decline in lung function and hospitalisation. And at the moment, our non-drug treatments are not highly targeted towards those at-risk individuals. To add to this, people with COPD don't only have COPD. Almost 90% of them will have at least one other condition, and cardiovascular comorbidities are incredibly common. And again, we have not targeted our non-drug treatments specifically to that group. So for the investigator trial, we're going to bring together 2 of our existing trials, quite large trials we're conducting across Australia with funding from MRFF. The TAPIT trial looks at people with COPD who have high risk of hospital admission, and the PERFORM trial is people with COPD and at least one comorbidity. And with the investigator grant, we'll be able to fund more detailed phenotyping of these patients and be able to really understand the response to rehabilitation in particular groups so we can target it more effectively. And finally, driving uptake of evidence-based care. Oxygen therapy will be very familiar to most of the people in this audience. It is a life-extending treatment for people who have low oxygen levels at rest. We have a lot of people who use it and it's quite costly. However, in Australia, I can tell you that there are 26 separate jurisdictions that have responsibility for it, and that's 26 governance applications we've done in the last 2 years and still don't have all of the data. So we don't know anything about how we're using it here in Australia or what it costs, or even whether we're getting it to the right people or whether it's equitable across the states. So what we're going to do is develop a core outcome set so that we agree on the outcomes that are most important to measure for people with oxygen therapy. And we're going to then pilot that in a clinical quality registry at a small number of sites to start with a view of scaling that up so that we'll be able to really drive best care in this area for patients with lung disease. So I'd like to finish by thanking my team, who are the people who do the work. And as Shane said, an investigator grant doesn't only make a difference for the person it's awarded to, it makes a huge difference for the team and the sustainability of the team as well. So thank you.
Thank you, Anne. First of all, my compliments on the complexity of the trial designs you have here. My background's quantum physics, and I see this stuff and I go, whoa, I'm glad I was in quantum physics, because the trials are getting complicated. They're getting more and more complicated. In terms of, you have the group that come into, obviously, the centres, and you have the online group. Is there a differentiation between the uptake that you get from those two groups? Because I can imagine some of these people are actually quite happy to be at home. And do the people who have access to the in-person ones also have the option of doing the online versions?
Yeah, that's a great question. I guess the frustration of our previous trials is we can't really tell that because they had to be happy to be randomised either way, so we couldn't really tell that. But in clinical practice, we've been lucky at the Alfred here that we've been able to roll out these programs into clinical practice, and our patients do have choice. And what I can tell you is that I think centre-based still is probably the predominant preference for most of the people who make it that far to get a referral and to accept it. But there is a significant minority who either want the virtual group program or would be very happy with a telephone supported program. And comfort with technology is certainly a big part of that, but also so is the home environment and what that looks like for that person. So it's quite complex choice actually often.
Yeah, indeed. And you mentioned with the use of oxygen and so forth, the complexity of 26 jurisdictions in Australia. Sometimes having a federated scenario works well for us, sometimes it doesn't. Are there advantages in so many small providers there, or is the only disadvantage your access to the data, or is it a significant disadvantage in the way it's rolled out across the community as well?
I'd like to come back in a few years and answer that question. What we suspect is happening is that there is inequity in what we deliver across those jurisdictions because the guidelines are local. For some they're state level, but for some they're very much even local health service level. And for instance, if you live on one side or the other of the border of New South Wales and Queensland, you may or may not be eligible for ambulatory oxygen at all. So I think there probably are substantial inequities, but we just don't have the data to be able to substantiate that and to push for change. So we're hoping that this is how we're going to get it.
Yeah. Obviously, these grants run over several years. Thankfully, they run over several years. What do you anticipate sort of coming out first as the outcomes from the grant midway?
Yeah, good question. So I guess we're fairly far advanced in terms of core outcomes, so that will be early, and I think initiation of the pilot registry will be early. That should happen hopefully next year if we get all the contracts signed. I think the larger trials will be longer because particularly the Smart PR trial will require additional funding once we've done the modelling. And probably midway along is when we're going to get some of that sort of detailed phenotyping data for our high-risk patients.
Yep, very good. We have time for one question for Anne before we finish up this part of the session. Anyone? No? Okay, well, in that case, we'll thank you once again, Anne. Great work. Okay, so just a couple of comments from me before I hand back to Adam to continue. I hope you enjoy the format of having our presenters speak for a shorter, more focused period of time. I'm not sure if any of you experience this, but when I go to conferences and talks are in excess of 15 minutes, I get this weird feeling in my forehead, and then it causes me to start looking for when the coffee break is. This happens to me at every conference I go to. So I think shorter, sharper presentations indicate that we can do better. We can communicate a lot more in a way that keeps us engaged. Because I remember some maths that one of my professors once taught me. He said, Shane, if you try and tell people 10 things, they'll remember 0. If you tell them 3, they'll remember 2. And it took me a while to work out exactly what he meant by that. But I think hopefully seeing these short, sharp presentations today, you'll take away quite a lot. Beyond anything else, you've all met 6 people today who have managed to get these grants. These are hard to get. Somehow, I'm not sure how, it could be the ridiculous number of publications a couple of them have, a range of other really good things about their work, but they've managed to get across the line. So if you're in the group that is looking to apply, you know 6 people here who've managed to do it. Be their best friend. Buy them coffees, buy them whatever beverage they want. Ask them how they went about it, because you can get all sorts of information from research officers and external consultants and everything, but no one is better at telling you how they got across the line than people who have been successful with grants. And it's often about how well they communicate in those documents. So 6 amazing people who've managed to do it. They're the ones that need to be celebrated, and they're the ones that you need to be best friends with. And you guys, you just got a whole lot of free coffees. I'm just saying, just a whole lot of free coffees. Okay, on that note, I'm going to hand back to Adam so we can continue.
Thank you, Shane. And again, on behalf of everyone here and online, just a thank you to Shane for anchoring another really impressive showcase event this year. And a particular thank you to our 6 presenters this morning. It's not easy, as Shane said, to condense your life's work into 6 minutes. And a particular mention to Jason, who managed with great poise to deal with the fact that none of his material appeared on the slides as well. But my main takeout from today is that we have incredibly impressive research happening across the whole campus. And it's research that will have great importance not only for individual patients, but also for the broader health system. And it's also research that has the potential to have an impact locally, nationally, and in many cases internationally. So a huge congratulations to you all, and good luck over the next few years as you roll out the work that you've received the grants for. Shane, please feel welcome to stay with us as we move into the next part of this morning's session, which is our abstract awards. And it's my pleasure to welcome Professor Stephen Jain, who amongst other roles is the Alfred Health Executive Director for Research. And Stephen's going to talk us through and present this year's Scientific Abstract Awards. Stephen.
So firstly, I'll just echo thanks to Shane very much. He has the unusual privilege of being a repeat performer at Alfred Research Week. You usually only get 1 gig, but I think he's so excellent that he's probably going to get the invitation in perpetuity. So you probably have to have a bad performance or 2 sometime, Shane, to get off the roster. But thanks so much. The Alfred Scientific Abstracts are an annual feature where we recognise excellence apart from what we've already heard, which I would echo the sentiments of Adam and others, really outstanding in an environment that is so challenging at the moment. You should all be incredibly proud of yourselves, and the diversity of subject matter was also superb and reflects the strength of this precinct. So congrats to all of you. And congrats to the abstract winners I'm about to talk to. We had over 200 submissions across public health, allied health, nursing, cancer, every medical discipline you can think of. Obviously, incredibly challenging selection in terms of quality. And we're going to go through with a range of awards, and Eva's here to take photos of the recipients. I'd ask Shane to join me to hand these out. The first prize that we're going to award is the Alfred Health Medical Service Prize for clinical research to a senior medical researcher, and a name that's familiar to many of us is Professor Paul Miles, Director of Research in the Department of Anaesthetics. Congratulations, Paul. And a high commendation was for Dr. Kay Hatak from the Melbourne Sexual Health Centre. The Alfred Health Medical Service Prize for Clinical Research for a Junior Medical Researcher. The winner this year is Rory O'Donoghue from Critical Care from Alfred Health. And unfortunately, Rory was not able to be here today to accept the certificate. And highly commended was Prasa Tharveen Thien, a neurosurgical registrar from Alfred Health. The next prize is from named after one of the doyens of allergy of the Alfred, who was around when I was a resident, Dan Zani, and it's the prize for allergy, asthma and clinical immunology research. And the winner this year is Miss Ebony Blight, a PhD student from Monash University. Congratulations, Ebony. We have two winners of the Monash Partners Comprehensive Cancer Consortium Prize for the Best Abstract in Cancer Research, and they are from Haematology, Joanne Tan from Alfred Health, and Philip McElwraith from Medical Oncology and Advanced Trainee with Alfred Health. Congrats to both of them. Oh, that's right. And Philip is with us, but online, and I'm just wondering how we're going to do the photograph for that one. But congratulations, Philip, in the background. This year, we also have two winners for the Noel and Imelda Foster Prize for Cardiovascular Research. Dr. Cheng Hui So, Research Officer of the Baker Heart and Diabetes Institute, and Dr. Joanna Gong, PhD student for Baker Heart and Diabetes Institute. Congratulations. Still with the Baker, the prize for cardiovascular research, and the winner is Ms. Hiaoang Fang, a PhD student from the Baker Heart and Diabetes Institute. And the Baker Institute Prize for Diabetes Research, repeat winner, Dr. Cheng Hui So, the Research Officer from the Baker. Congratulations again. The Burnett Institute Prize for Infectious Diseases Research. The winner this year is Dr. Lucy Atwood, an ID physician, PhD student with Alfred Health, Monash University, and of course the Burnett. Congratulations. A new category we have this year is in rewarding excellence in neuroscience. The School of Translational Medicine Monash Prize for Neuroscience Research goes to Dr. Georgia Simons, a research fellow with Monash University. And the Monash Alfred Psychiatry Research Centre, MAPRC, Prize for Psychiatry Research. The winner is Dr. Lakshini Gunasekera. And the final prize was in recognition of a very talented young respiratory registrar who tragically passed away from a cardiomyopathy around about the time I was actually a registrar as well, and I think shook the hospital to its foundation at the time. But Michael's memory has been honoured for many years through his family, the Michael Hall Memorial Prize for Respiratory Medicine, and the winner this year is Dr. Lena Lai, Postdoctoral Research Assistant, Alfred Health, Monash University, and Lena unfortunately couldn't be here to accept her certificate. Thanks again, Shane. Thanks, Eva, for the photography. Thanks, Ursula and the team for putting it all together. Much appreciated. Thank you, everyone, for coming today. As you know, this is the forerunner of Research Week, the entree, main course, dessert to follow. Tomorrow is the important keynote address, which is really the showcase piece of Alfred Research Week. And we're very lucky this year to have Ainsley Kale, who's the chair of the NHMRC MRFF Consumer Advisory Committee, which is the theme for this year's Research Week of research engagement with consumers. So I would encourage you all to be here tomorrow. And we also announce the winners of the 2 publication awards for both basic science and clinical research tomorrow as well. That's here at 11 o'clock. Thank you all for your attendance today. Thanks again, Shane, for your participation, and I wish you have a good day. Did I miss something?
No, not at all.